Hello everyone, welcome back to the Lifestyle Medicine and Metabolic Diseases discussions. Today we will discuss a recent paper published by Professor Mark Atkinson on type 1 diabetes. Over the past decade, knowledge of the pathogenesis and natural history of type 1 diabetes has grown substantially, particularly concerning disease prediction and heterogeneity, pancreatic pathology, and epidemiology. Technological improvements in insulin pumps and continuous glucose monitors help patients with type 1 diabetes manage the challenge of lifelong insulin administration. Agents that show promise for averting debilitating disease-associated complications have also been identified. However, despite broad organizational, intellectual, and fiscal investments, no means for preventing or curing type 1 diabetes exists, and globally, the quality of diabetes management remains uneven. Today, we will discuss current progress in epidemiology, pathology, diagnosis, and treatment of type 1 diabetes and prospects for an improved future for individuals with this disease. Let's get started. Type 1 diabetes is generally thought to be precipitated by an immune-associated, if not directly immune-mediated, destruction of insulin-producing pancreatic beta cells. Historically, type 1 diabetes was largely thought of as a childhood or adolescent disorder, but that opinion has changed in more recent years. It's not uncommon now to see people with diabetes suffering from type 1 at a higher age than before. Polydipsia, polyphagia, and polyuria are three classic early symptoms of type 1 diabetes. They can occur in adults as well as children, although they're less common in adults. Hyperglycemia, overt symptoms manifest when blood glucose levels are above the diagnostic range. People with type 1 diabetes also experience an immediate need for exogenous insulin replacement. A lifetime treatment is needed for their condition. Key questions remain unanswered on the epidemiology of type 1 diabetes, the effectiveness of current therapies, and understanding how this disorder develops. Preventing or curing this disease is also difficult at the moment. Epidemiology. Type 1 diabetes is most common in kids and teens. The age of diagnosis ranges, but it's often around the 5-7-year-old range and at puberty. The majority of autoimmune disorders predominantly affect females, but type 1 diabetes is more common in men. The incidence of type 1 diabetes varies depending on the season, with a higher number being diagnosed in autumn and winter. People who are born in spring are more likely to have type 1 diabetes. Several concepts can explain the origin of type 1 diabetes. Understanding and finding these origins have been difficult due to the broad range of rates of incidence and prevalence around the world. It's well known that type 1 diabetes has different incidences in different countries. For example, there are wide variations in disease incidences among neighbors such as Europe and North America as shown in the graph. The incidence of type 1 diabetes worldwide is on the rise, with new studies showing a 2.5% increase every year in some countries in Europe. There has been an unfortunate, but the predictable rise in the number of type 1 diabetes cases in countries all over the world. Research shows that this trend is projected to continue, and by 2035, the global incidence rate will more than double. There are many different types of diabetes, and the mechanisms behind their occurrence are not fully understood. It is largely thought that these mechanisms arise due to external factors, but we don't know for sure. Genetic changes among mothers with type 1 diabetes cannot solely explain such rapid rates of increased incidence. Finally, genetic predisposition seems to be less of a factor now than it was in the past as a prerequisite for developing type 1 diabetes. A plethora of environmental factors is thought to have some influence over whether people develop type 1 diabetes. Some of these factors include diets during childhood, adolescence, and adulthood, vitamin D or its constituents, and viruses. There has been a lot of interest in research models that could explain what factors influence type 1 diabetes, such as hygiene and the gut microbiome. However, no specific agents have been identified that have a definite influence on the development of this condition. Diagnosis. Diagnosis of diabetes has historically included fasting blood glucose higher than 7 ml per dl or 126 mg per dl and blood glucose of 11.1 ml per dl or 200 mg per dl or higher with symptoms of hyperglycemia or an abnormal 2-oral glucose tolerance test. In 2009, the American Diabetes Association changed its guidelines for diagnosing diabetes to include glycated hemoglobin as a diabetic test. The higher than normal levels of blood glucose can be found in a HbA1c test, which is checked over a period of 3 months when it's 6.5% are higher. Despite various efforts to standardize the diagnosis of type 1 diabetes, the causes and typology remain unclear. Diagnosing type 1 versus type 2 diabetes is especially tough when it comes to adults. Some studies have found that around 15% of adult type 2 diabetes patients might actually have type 1 and may not be properly diagnosed. And if this is the case, as many as 50% of what we think are type 1 cases may be type 2, which would mean that the number of people suffering from diabetes is much higher than we thought. Diagnosing this condition is important for providing effective treatment and decreasing the likelihood of developing complications. If you can correctly diagnose diabetic ketoacidosis in a patient with type 1 diabetes, it's crucial that you act quickly to avoid permanent damage. Efforts to isolate type 1 diabetes from type 2 in adults have led to the proposal of new classification types, including latent autoimmune disease in adults and ketosis-prone diabetes. The lack of set guidelines for diagnosing latent autoimmune diseases in adults has made it tough for medical researchers to be enthusiastic about adopting it. Meanwhile, clinical symptoms may overlap with that of type 1 diabetes. Disease heterogeneity. Most cases of type 1 diabetes appear to be triggered by the immune system, if not an autoimmune response. Multiple features of autoimmune responses are often found in these patients, such as antibodies we see in autoimmune diseases are genes that control how the immune system works. However, not all patients with type 1 diabetes have these characteristics, leading to the proposed classification of type 1A autoimmune diabetes. This form accounts for 70-90% of people diagnosed with type 1 disease who don't have any immunological problems, but are also diagnosed with type 1B idiopathic diabetes, can represent rest. Pathophysiology. Most research articles on type 1 diabetes start by mentioning the autoimmune response that leads to the gradual destruction of insulin-producing cells. Chronic immune cells and inflammation in the pancreas can be seen at the onset of type 1 diabetes. Another theory is that in patients with long-standing disease, the insulin-producing cells of the pancreas have died off and cannot regenerate. This has been proven to be wrong for type 1 diabetes. There is some evidence for B-cell regeneration which might account for the differing levels of better outcomes in infants, but not adults. Much of what we know about the causes of type 1 diabetes comes from analysis of cells found in patients with the condition. Studies of type 1 diabetes patients have shown that a series of genetic defects in the bone marrow and thymus, immune system, and B cells contribute to the development of this condition. Pancreatic pathology. Most studies of pancreatic pathology of type 1 diabetes involve retrospective, sample-based analysis of pancreata obtained at autopsy from individuals who died at or near the time of diagnosis. Most studies reveal a variety between islet cell and whole organ features. Several studies have shown that about 70% of your islets should be free from insulin. When you look at glucose production, nearly 20% of islets that have insulin still produce some amount of insulin in inflamed pancreata. In contrast, only 1% of the islets that don't have any insulin are also inflamed. This means that not all pancreata are inflamed, some have many normal islets, and only a few with inflammation. In people with type 1 diabetes and surviving islets, the insulitis lesions are usually found in a lobular pattern, just like melanocytes in vitiligo. It's often stated that symptoms occur when 90-95% of beta cells are lost, but diagnosis of type 1 diabetes can be made when roughly 2/3 of the islets are devoid of insulin-producing cells. Among individuals who have had type 1 diabetes for more than 5 years, most of the remaining islets are insulin deficient, containing a normal complement of other hormone-secreting cells, that is, the cells that secrete glucagon, D cells that secrete somatostatin, and PP cells that secrete pancreatic polypeptide. Thus, type 1 diabetes involves a selective loss of B cells. In terms of potential pathogenic mechanisms, CD8 plus T cells are the most predominant population within the insulitis lesion, followed by macrophages with CD68 plus and CD4 plus T cells. Although a lot of attention has been paid to inflammatory cells, researchers have also noted that natural killer cells and regulatory T cells are comparatively rare in this lesion. It's not clear whether these findings represent a stromal failure or some other cause for the lack of B cells and immunoglobulin G as one would expect. One of the most underappreciated aspects of disease might be the pancreatic size. Recent efforts suggest that at the time of diagnosis of type 1 diabetes, that is, autoantibodies are present, affected individuals have a smaller pancreas compared with age-matched, BMI-matched, and age plus BMI-matched individuals. This is shown in the absence of insulitis, which implies that there are multiple mechanisms involved in the loss of B cells related to type 1 diabetes. Serological. Type 1 and 2 diabetic patients differ from one another by the presence of autoantibodies against B cell autoantigens. More than 90% of people with newly diagnosed type 1 diabetes have one or more following autoantibodies: those that are reactive to insulin, glutamic acid decarboxylase, insulinoma-associated autoantigen 2, and zinc transporter 8. These autoantibodies can appear as early as 6 months of age, with the peak incidence before 2 years of age in genetically susceptible individuals. Thus, they are present for a few months or even years before symptomatic onset. Type 1 diabetes has a diagnostic value, and autoantibodies help identify people with an increased risk for type 1 diabetes. You can find out if they have a better chance through first-degree relatives or the general population. Insulinoma-associated autoantigen concentration is a significant predictor of progression to type 1 diabetes in children. Researchers have discovered that proinsulin is an important autoantigen in humans and rodents with type 1 diabetes. Not only does this new finding reinforce a concept about the disease, but it might explain why we are seeing greater improvements in treatments for patients. Another study found higher concentrations of odd-chain triglycerides, polyunsaturated fatty acid containing phospholipids, and lower concentrations of methionine in those who developed type 1 diabetes-associated autoantibodies. Genetics. Type 1 diabetes is a disease that's controlled by many genes, which make it likely for someone to develop the disease. However, despite this prevalence of gene-based errors in its development, there has been very little progress in type 2 diabetes treatments. The HLA region on chromosome 6 provides about one-half of the genetic risk for type 1 diabetes. Of the many HLA types, HLA class 2 shows the strongest association with type 1 diabetes, where haplotypes T are bound by 401, DQ bound by 302, and D are bound by 301, DQ bound by 201 confer the greatest susceptibility, and D are bound by 1501 and DQA1 by 102, DQ bound by 602 provide disease resistance. Class I MHCs seem to influence the risk for type 1 diabetes independently of class 2 molecules. Of the remaining loci, only those for the insulin VNTR, PTPN22, CTLA4, and IL2RA are associated with odds ratios greater than 1.1. Researchers suggest that most of the loci related to type 1 diabetes are related to immune responses, supporting the notion that genetic influences exist with mechanisms that collectively contribute to aberrant immune responsiveness, including genes like DPEP1 or ZBTB10. This mechanism might help explain why, in adults with type 1 diabetes, there are often more fluctuations in clinical progression than those that occur in children. The study showed that genetic susceptibility might also influence responses to environmental stimuli or physiological pathways, for example, vitamin D and interferon-induced helicase. Natural history. Environmental influences might occur as early as in utero and probably continue during the first months of life. Onset and continuance of beta cell autoimmunity are likely to be affected by this. Possible physiological factors, which include the development of the immune system and the normal turnover of beta cells, might also contribute to these pathogenic processes. Over time, individuals develop an immune response to the insulin that's produced in their kidneys. This can eventually lead to a failure of the insulin-producing cells and result in diabetes. By looking for genetic markers such as those associated with type 1 diabetes, scientists can figure out if any pre-existing risk factors may be driving this development. After someone is diagnosed with type 1 diabetes, insulin can change how their body metabolizes sugar for months or even more than a decade. People with anti-beta cell autoimmunity often don't develop the overt disease, but for unknown reasons, not everyone develops it. The first sign of type 1 diabetes is a reduction in natural insulin production. Around 2 years before their onset, the body begins to produce less well-regulated glucose levels, as triggered by an early response to the disease. Once this is done, the body's natural insulin production begins to break down and symptomatic symptoms started developing with a prescription for exogenous sugar pills or insulin injections to prevent the progression. The symptomatic onset of type 1 diabetes is often considered asymptomatic when the disease is diagnosed early. Patients with multiple autoantibodies may develop a diagnosis during a silent phase that lasts for months to many years. The most common cause for this is genetically susceptible individuals. This disease feature will likely have implications in detecting, defining, and providing information about the stage of decline and the effect of therapeutic interventions. After diagnosis, some patients still have residual B cell function and can manage their blood sugar levels better than those patients who don't have this ability. Your health and longevity need to know the time it will take for your blood sugar levels to operate as they did before, in addition to knowing how many people out of 100 are not affected by diabetes. Thus, the heterogeneity of type 1 diabetes is an important factor in determining how well it can be treated. The genetics and age of onset of the person also play a role in their ability to retain B cell function. Future care, insulin pumps, and continuous glucose monitors are a great source of comfort for people with diabetes. Such tools are making substantial progress in improving the lives of people with diabetes, including providing additional improvements to come shortly. Experimenting with AI systems to detect hypoglycemic episodes and then controlling insulin via pumps has been an ongoing process. Reducing the need for monitoring glucose levels with a computer algorithm or artificial pancreas is another way to improve the efficiency of diabetes management. The integrated closed-loop systems tested so far have reported favorable results when comparing the safety and efficacy of overnight closed-loop delivery of insulin with conventional insulin pump therapy in adults with type 1 diabetes. Closed-loop delivery improved overnight control of glycemia and reduced the risk of nocturnal hypoglycemia. New continuous glucose monitors are expected to have improved signal transfer and lower accuracy without the need for finger stick calibration. Reversal of diabetes. Currently, there are no approved drugs to stop the autoimmune destruction of B cells after diagnosis of type 1 diabetes. In the past 5 years, interest in reversing type 1 diabetes has grown. The process of creating a drug that inhibits autoimmune destruction and does not trigger B cells to produce C-peptide. Many therapies involve the provision of vaccines or suppression of the immune system. Unfortunately, phase 1-2 trials in patients with recent onset type 1 diabetes were disappointing. There must be a reason why phase 3 trials of anti-CD3 antibodies such as otlixizumab and teplizumab and the diamide vaccine or gad-alan have been approved. Administration of diapep 277 may lead to a sustained level of C-peptide after 1 year in adults with type 1 diabetes due to less decline. Another phase 2 study of immune modulators showed evidence of therapeutic efficacy in settings of recent onset type 1 diabetes. However, even with continued use, most didn't show durable effects. For example, researchers found that fusion protein CTLA4 or abatacept had a preserved stimulated C-peptide concentration for 9 months. The difference is despite continuous intravenous administration for 2 years longer than if the patient had not been given the treatment. These results imply that single-agent immunosuppression alone might be insufficient to completely control B-cell destruction, or that more specific and targeted therapies are needed. Combination therapies that target several pathogenic pathways and improve B-cell viability could be needed to preserve endogenous insulin production in patients with type 1 diabetes. Cytoxan and thyroglobulin have been used in a 2007 trial of autologous hematopoietic stem cell transplantation combined with high-dose immunosuppression. They help to increase C-peptide production and insulin independence in most patients who received the treatment. However, the effects of invasive treatments waned over time, with the loss of insulin independence in most patients after 5 years. Importance of re-examining study design and metabolic and immunological outcomes of trials to understand disease susceptibility genes for a more promising approach for type 1 diabetes. Additionally, tests targeting inflammation, such as anakinra and canakinumab, are effective when used alone or in combination. Other drugs such as insulin APL at phase 2, anti-CD20 rituximab at phase 2, anti-CD3 or teplizumab at phase 3, CTLA4 immunoglobulin fusion protein or abatacept at phase 2, anti-CD3 or otlixizumab at phase 3, GAD65 protein or diamide at phase 3, HSP60 or diapep 277 at phase 3 under trials. Unanswered questions in diabetes treatment or management despite technological and scientific evolution. Diabetes is a commonly known and very well studied disease, but progress in the field of type 1 diabetes has been tough. It might seem like the principles are much easier to grasp now that they've tried something over the ages, but there have been medical advances made recently that put learning all these principles into context. Despite many advancements in the field of insulin resistance and design, some researchers are disappointed by a lack of progress. There are several promising areas in terms of time, finances, and patient resources that have been directed toward research over the past few years. These include islet cell transplantation, stem cells, genetics, primary and secondary disease prevention, as well as reversal of type 1 diabetes. Type 1 diabetes is often thought to be more resistant than initially expected to therapeutic interventions with conventional or experimental agents. It offers great opportunities for preventing and reversing the disease and also has a high survival rate even in unreversed conditions. The inability to overcome the autoimmune nature of this disease, perhaps the result of robust immunological memory combined with a failure to attenuate deleterious immune responses that are not subject to normal regulation, is a hurdle that presents problems. Islet cell transplantation should be avoided by patients. To avoid the risk of autoimmunity, subjects should receive allogeneic-sparing operations such as replacing an organ with islet cells from a different donor. At this point, a limited donor pool and the need for chronic immunosuppression are common hurdles in islet cell transplantation. However, there are methods to induce long-term immunological tolerance, which allow for functional engraftment. While many genetic associations with diseases exist, the specific phenotypes resulting in these genes are largely unknown. This complicates the treatment of the disease. A group of scientists is trying to use genotype information about a person's genes to decide their risk for developing type 1 diabetes. They are attempting to assign specific phenotypes and increase understanding of how genetic conditions influence the disease. Many people are having difficulty understanding the genetic complexity of type 1 diabetes. There is a lack of knowledge about how the immune system responds to this condition, and that can make it difficult for many patients to take appropriate treatment measures. Despite decades of investigation, we don't know exactly how B cells are eliminated or selectively destroyed. For much of the last decade, investigators have devoted a lot of effort to describe how adaptive immune responses cause type 1 diabetes. The innate and adaptive immune response, as well as the role of beta cells in type 1 diabetes, are aspects that have great relevance for the development of improved therapies. The guidance and support of these trial networks not only can help companies find agents capable of providing therapeutic benefits, improving patient recruitment, and increasing the precision of disease prediction, but also make them more sustainable. An additional change that could improve the effectiveness of type 1 diabetes research is changing the clinical trial design. This would also allow for more effective therapies to be identified and new definitions of the disease's heterogeneity to be considered. There are also animal models that can be used that could increase the effectiveness of research. Type 1 diabetes didn't just happen overnight. It has a set onset period and is the result of an autoimmune disease process in which the body starts attacking its cells. Redefining type 1 diabetes as having a silent or asymptomatic state, for example, multiple autoantibodies, genetic risk with varying degrees of dysglycemia could allow therapeutic interventions to be given earlier in the natural history of the disease. The concept behind patient-centered care is based on animal models, where earlier intervention seems to be more efficacious. Unfortunately, this model has not been tested in humans, and while some studies claim that a loss of less than 10% of the remnant B cell mass leads to serious consequences such as heart failure and severe prolonged hypoglycemia, no human trials have, for example, glucose toxicity, stress response. Where do we go from here? Type 1 diabetes is a disease that has faced many decades of knowledge voids. Type 1 diabetes currently has greater gaps in understanding environmental contributors than other known diseases, but the most pressing question remains: what environmental constituents unequivocally contribute to the formation of type 1 diabetes? In what way does genetic susceptibility contribute to disease development? Can a safe and effective closed-loop therapy system be developed? What drugs should be used in attempts to prevent or reverse type 1 diabetes? Are agents capable of instilling long-term immunological tolerance available? Can improved markers for predicting disease development be obtained? Can B-cell replication and neogenesis be safely induced in humans? Finally, why are pancreatic B-cells specifically targeted for destruction, and do inherent processes contribute to their demise? These questions form a roadmap for the next generation of investigations. By addressing these, you should be able to make substantial improvements in the lives of those living with type 1 diabetes.